All right. How many people here are actually, you'd call yourself innovators or entrepreneurs? What proportion of the room? Don't be shy. Come on, come on, come on. Because if it's only like 6, then we should all go home. All right, so that's good. It was really interesting listening to the various sponsors and partners introduce themselves and talk about their contribution, because that also took care of the first 3 minutes of my remarks. So lucky for you all. But I think there's a couple of themes that I want to leave with you before we move on. One is the true importance in this environment of partnerships and collaborations, and not in a soft, esoteric way, but in a really tangible, if we're going to get the stuff that you're going to develop adopted into our health system in Ontario and abroad and diffused throughout that health system, it is absolutely going to depend on partnerships and collaboration. So efforts like the summer program they just epitomize how important it is. And then when you look at the partnerships and collaborations and then when you look at the people that are participating here, you've now heard from each of them. But our office has worked with all of them, and it's a pretty impressive roster. So I think I met with Venture Labs the first month I was in the job, which is almost 2 years ago, which is horrifying for me. But anyway, I don't know if there's a RIC that's stronger than Venture Lab anywhere in Ontario. They have a great ability to deal with referrals and companies in particular, and to build the relationships with the hospitals, and are starting to put those, have started to put those things together in a meaningful way. That's really, really critical to success in this health innovation ecosystem. You've heard about the hospital. I'm not going to repeat those words, but as I was saying before we all got going, from the very beginning, I have said that I think the adoption of innovation is going to happen faster and in a more varied way at the regional community hospital level than it is at some of those, teaching hospitals down in the other part of Ontario. And it's not to be critical of anyone. It's just different people doing different things. But you've seen it in Markham Stouffville, and you see it in other places like South Lake, where you've got people doing different things and doing things differently, honestly, in a faster, more nimble way than some other parts of the province. And that really, really needs to be celebrated. I've already been at Seneca, where you've got tremendous leadership. You're going to hear from David later in the day. A great example, as the councillor said, of true excellence at the college level in Ontario. And IBM, who didn't get the podium, I don't know, what happened to IBM? But IBM, so, we spend a lot of time in this role and in this effort talking about Ontario's small and medium-sized enterprises and how important they are. But we're building a health innovation ecosystem. That's what should be exciting to those of you who are coming up with these ideas and looking to build the companies. We are building a health innovation ecosystem to scale those companies up. And it is not mutually exclusive from the great ideas and investment of multinationals like IBM. I've been at a number of events, most recently I think in June in Hamilton with Hamilton Health Sciences and IBM, where they were perfect examples of that, that company's ability and willingness to be a true partner and collaborator with investment, with ideas, with talent. All of these things, including research, academia, private sector, public sector, and government, right? York Region, City of Markham, Government of Ontario, the federal government, all of these people are coming together to make this time, I think, particularly opportune for those of you who are so shy to put up your hands about 3 minutes ago. I think that this is an unprecedented time in Ontario for people who are entrepreneurs and innovators in health technologies and health processes. This is the beginning of a fundamental shift in the way this system looks at adopting and diffusing new innovative health technologies and processes. And at the Office of the Chief Health Innovation Strategist, we are absolutely thrilled to be so closely involved with it. I really consider this to be a privilege to be working in this capacity. So I'm going to just talk about a couple of things. Am I? Does that work? So all I want to do to talk about with respect to our office is I think it would be interesting to hear why we were even created in the first place, a brief overview on what we're doing, and then also, because this is also forward-looking, beginning with the pitches you're about to give, on where we're going. The office was created because we have a burning platform in Ontario when it comes to a need to invest in health innovation. The health innovation imperative has at least two components. You might think, and I think honestly until very recently, people in Canada thought they were separate. They're not separate. They're absolutely intertwined. The first is a clear economic development imperative. We are going to have to invest in health innovation if we want our kids, frankly, the people who are pitching soon, if they want you and our children and grandchildren to have meaningful, sustainable jobs in the second half of the 21st century in this province. We are not going to win in the low-cost industries that we've been able to win in so far. Advanced manufacturing is always, I think, going to be an important part of the Ontario economy. But low-cost manufacturing, no. Because there are societies and regions of this world that are just more willing and frankly able to pay their people less. We can't compete and win in that environment in the way we used to. We'll still win some, but not in the way we used to. Similarly, natural resource extraction is going to be different going forward than it has been in the past. So that means that we're going to have to win in a knowledge-based economy. And there are going to be winners and losers. Just ask the folks that live in places like Detroit, as opposed to those who live in Boston or Silicon Valley. About 50 years ago, the 5th and 7th largest cities in the US were Detroit and Cleveland, Ohio. Can you imagine? And Boston was a place you'd go to if you loved sports, American history, or maybe your kids were in one of those great university institutions. And Silicon Valley didn't exist. There were a couple of defense contractors that were starting to figure out a way to communicate with each other in a completely different kind of unheard of way. Boy, how things have changed, right? Now, not solely and entirely because of the investment in innovation in a particular industry or the lack thereof, but principally. Detroit's starting to come back. Cleveland has things like the Cleveland Clinic, which is a health innovation ecosystem in itself. But those are not the economic powerhouses they were 50 years ago. And of course, Boston and Silicon Valley are as good as they get in the world. That is how quickly things can change. So we're going to have to compete to win in the knowledge-based economy, and it's going to mean we're going to have to invest in innovation. McKinsey, BCG, these folks will tell you, if you're going to take that on, you need to find industrial sectors that are fast-growing and in which you have a competitive advantage, which brings us to health. We have a $52 billion business on the way to being a $60 billion business of healthcare in Ontario. Business. 2017, the notion of social enterprise as a business is tried and true. This is not 1975. We don't think like good, bad, black, white, industry, government. That's not the way you think. It's not the way you're taught. It's not the way high-performing organizations function. It is a social enterprise to deliver high, world-class health care to the citizenry. Until very recently, it was just seen as a cost center. You'd only hear about the cost of healthcare kind of around the provincial budget cycles or maybe the federal budget cycle. And then there'd be a 4-page spread in the local newspapers, and it would either be too much spent on healthcare or not enough and all sorts of other things. It's more than that. It is the fastest growing job and wealth creator in the 21st century. Half of the Fortune 50 companies are in healthcare. And it's not just Pfizer, or a big pharmaceutical company. It's Microsoft. It's Google, it's Apple, it's Ford trying to figure out how to deliver healthcare or at least monitor such things in an autonomous vehicle. It is McKesson, it is absolutely a fast-growing industrial sector. So we have such a competitive advantage because we actually own the end user. We are a single-payer central system, owned and operated by one person. Now, there's a lot of air quotes, air bunnies going on, right? Because it's government, so, it's not exactly the same, but it's close enough that we should be looking at how we invest our money in healthcare to ensure that we are also winning in this really important knowledge-based industry, and we can do that. Absolutely no reason why the next Baxter or Medtronic couldn't come into the greater Toronto-Hamilton area, for example. None. With those resources, these resources, the people, urban environment in which the world wants to live, full government support from every level, whether it's municipal or provincial or federal, absolutely no reason why the next big company couldn't come out. And we have companies, to give you guys some hope, we have companies that are now in the past, starting in the last sort of 2 or 3 years, are on that path. Point Click Care, 1,300 employees, one of the biggest, if not the biggest, provider of IT solutions in long-term care facilities. Synaptive, world-leading imaging technologies, have now moved down to King Street and Wellington Street with full manufacturing facilities in downtown Toronto. Go figure, right? That's okay, that's not bad, by the way. There's lots to go around. But that's another great example. Think research, broadening from digital order sets onto e-referral and other digital technologies. These are Ontario companies. The ideas you have, by the time they get to market, you are going to have an increased receptor capacity in Ontario's healthcare system that will allow you to have Ontario as a reference customer, at least to allow you to export, and our ability to adopt and diffuse even throughout our 13 million patient system will be decidedly better. That should give you all kinds of optimism as you start to think about how to commercialize the ideas that you're going to pitch. All that I've said has to do with the first of 2 planks in this health innovation imperative. The second one, and this is at least as important, is the sustainability of our healthcare system. So, let's say that our healthcare system is sustainable as it's currently constructed. Let's say that that's true. Let's say that with that huge bundle of people that are aging, with all the issues that they're going to face, like ALC and others, dementia, the idea of living with chronic, diseases that are chronic conditions now that weren't before. Let's just say that our system is going to be able to handle all that. Well, the only way it's going to be able to handle that is if we are able to invest in innovation. If we stop thinking of innovation in the healthcare system as like the responsibility of some man or woman who sits over here in a Chief Health Innovation Strategist office and thinks about innovation. I'm going to start counting the number of times when I'm in meetings with healthcare professionals, serious, super smart, hardworking, passionate people, where somebody says some version of, literally happened 2 days ago, innovation's too expensive. So think about that for a second, right? Nobody runs a business or a high-performing organization, whether it's community-based or private or a mix or whatever it is, nobody can run that successfully if we think of innovation as a nice to do over here. It's not going to work. It's not going to keep the system that we have, let alone build the one that we're going to need to have to deliver what we need to deliver to the citizens in the second half of the 21st century. It's not even second half, second quarter of the 21st century. So that notion of having to invest in health innovation to improve our healthcare system is at least as important as an economic development. But here's the awesome part of this. In the Venn diagram, there's so much overlap, the cross-hatched areas in the middle, that it makes this job really exciting. So with all that in mind, the government of Ontario was the first government in Canada who had the vision of actually looking to leverage the amount of money we invest a lot in our healthcare system as an economic driver. And they looked at the fact we had this $52 billion business, the end user right here, with a really strong health innovation ecosystem, lots of small and medium-sized enterprises. I've named some of them. Cloud DX is another great example. Lots of these companies in Ontario that are growing, but principally on the back of exporting to the US, Western Europe, Middle East, increasingly China. Our Ontario system, this incredible 13 million patient end user we have right here, is almost impenetrable in many circumstances to these companies. That's the missed opportunity. So that's why we're here. How can we use that system, leverage that system, the money we've invested that system, to not only improve patient outcomes, but to actually create jobs in Ontario in the process? So they created this office. And our purpose statement captures all that. Interestingly, you'll see words in there that have been mentioned a number of times already. It goes back to partnerships and collaboration. So our office has a small band of merry warriors. When we're all staffed up, we'll be 13 full-time equivalents, FTEs. We're not going to be able to deliver healthcare in the way that we want.
Room 17, cold blue, 3WF, room 17, cold blue, 3WF, room 17.
Far more important than what I'm talking about. So our success, we will live or die on the back of our ability to drive collaboration, to get people to work with us and work with each other. So our purpose statement focuses on that. It's to drive collaboration across the healthcare system to accelerate the adoption and the diffusion, the spread, of new innovative health technologies and processes with those three purposes: to improve patient outcomes, add value to the system, so that's cost effectiveness. So let's remember that as you look to develop your products, right? They have to add value to the system. Whether you're talking about a public system like ours or private system like they have in the US, although it's increasingly a mix there too, or the mixed systems in Western Europe, everyone now is looking at some version of assessing value of the innovation that's coming forward. It's got to do more with the same, more with less, do the same with less, right? You need to find the way that it's more than just that super cool idea that you came up with. It needs to be that, but it also really increasingly needs to be applicable to the particular system you're pitching to improve patient outcomes at the same, or I don't want to say cost. Value is a much better word. I don't like cost effectiveness. It's value. So those are the three purposes that our office is targeting. We have, from the beginning, we said we were going to run our office like a business. So we had to really focus on having impact. Whether I give 50 or 100 speeches doesn't matter. It doesn't really matter even how many meetings we host. We're not in this to create more work for really busy people like Joanne. That's not what we're doing. We want to have impact. So we had to prioritize ruthlessly. We do not have the ability to focus on biopharmaceuticals, for example. The path to commercialization of a biopharmaceutical is clear. It is not clear for non-biopharmaceutical health technologies and processes. That's the path we're focusing on. So there are two overarching priorities, and I could do a speech. As you can probably tell by now, I love to talk. Lucky you. You can do a speech on each one of these 5 priorities. I'm not going to do that. I just want you to get a sense of what we're working on, and then I'll talk about the principles that are guiding our work going forward. There are 2 overarching priorities and 3 areas in which we really chose to dig in. The first overarching one is optimizing the pathways to the adoption and diffusion of innovation. This came right out of the Ontario Health Innovation Council that the government created. They recommended the creation of this office. They also really focused on this point of pathways, and I thought it was, maybe they're the best part of that whole report. It simply said, in a private sector enterprise where you're driven by the profit motive, where you have to get customers and you have to do it in a truly cost or value effective way, you create a pull for innovation. There's a natural pull. So I'm not advocating private sector delivery. That has nothing to do with this. I'm just saying that natural pull that would exist in a private sector enterprise doesn't necessarily exist in what we're doing. It should. We should all be thinking, hey, let's get innovation in because we'll be able to give better patient outcomes and we'll be able to do it in a more value effective way. But that's not an instinct yet, so we're working on that. So we are looking at the barriers and the hurdles to that in those pathways to really create that pull, create a demand-driven pull. The system identifies the problems for which it needs solutions, and it creates, facilitates the introduction of those solutions. Biggest block, risk aversion. It's not even risk aversion. It's like desire for zero risk. If you actually, and I'm not being facetious, if you actually operated your life where you were risk intolerant, zero risk, you literally wouldn't cross the street. You wouldn't drive your car. You wouldn't get on a plane. It is not prudent risk management. It's something more than that. It's not, and it's also not bad or incompetent people or anything like that. It's really good, smart, hardworking people responding to the stimuli in the system in which they find themselves. And as somebody way smarter than me at Harvard said at one point, every process is designed perfectly to produce what it produces, right? And that's kind of what we have. So whether it's the funding formula, which we can look at, or concern that legitimate political concern that you'll find yourself on the front page of a newspaper because you've made a mistake, the best of intentions, but you guessed wrong on an innovation investment. Or a system where you've got layers of bureaucracy, and it's kind of the pejorative sense of the word bureaucracy. In other words, it's just kind of easier to say no than it is to be that person that doesn't say no, says yes, and then finds the way to get that innovation into the system in this case. Anyway, all super smart people doing great things. We need to find the way to get people more comfortable with doing what is absolutely critical to the adoption and diffusion of innovation. Taking risks. Prudent risks, manageable risks, but you have to be willing to take risks. So that's the biggest challenge for us on Pathways. One of the cool things we've done, I think, is we've hired 3 innovation brokers. So take note of this as you think about the next little while. These are field-based people. So they don't work in our office. They're more like political constituency assistants or
Code blue, 3WS, all clear. Code blue, 3WS, all clear. Code blue, 3WS, all clear.
it's good news, I think. Must be. Okay. I shouldn't joke about that. Okay, so they're field-based people. So think political constituency assistants, community outreach, even good sales reps for that matter. They're in the field, which means they have insight. It's more than the virtual Rolodex. They kind of know why people are doing things, what didn't work, what could work, what they're really looking for. And that's what these folks will do. These are really senior people in Ontario's healthcare system. For those who are in the system, they recognize those names. Their purpose is to put deals together, increase the receptor capacity for, in this case, the teaching hospitals, but our next stop is the OHA, for example. And in Jennifer's case, develop the tools that small and medium-sized companies can use as they look to bring their ideas forward to help them scale up. So the innovation brokers is one of the things we're doing to optimize that pathway. That quickly, though, gets you to the second overarching priority, which is procurement. Not a super sexy topic, but at the end of the day, we could do everything right in every other category if we don't fix an Ontario health procurement model that's principally cost-based. So in other words, ideas come forward and the instructions to the people doing the buying are, we want the lowest price. Again, for those of you in the investment, in the innovation environment, you will know that will usually lead to a decision that is not innovative. It preserves the status quo. It at least chooses the safe option. Probably from a long-established company, probably with long-established technology, and probably to suboptimal outcomes. And also probably, in the long run, more expensive and less valuable to the system. So, we're well on the way to that. The council, another recommendation of that council was to shift to value-based procurement. We've done that. There's an expert panel struck by the government that has reported and made that recommendation. We've begun that shift. Hospitals like Markham Stouffville and Southlake and Mackenzie, these are hospitals that are exercising that muscle. Let's move to value-based procurement. And without digging too deep into it, that simply says that on a list of criteria, assessment criteria, yes, of course cost is important, but value has different components. And how you structure that can make a tremendous difference as to what product is decided, is the successful one. And value can be whole value, whole cost of operation, likelihood of replacement, impact on patients, impact on health service providers. Because you know who else gets frustrated with not being able to bring innovation into the system? Healthcare practitioners, the doctors, the nurses, everybody. So all these things can be considered as part of value, and we're really working on that. And one of the most important things we're doing that ties those two priorities together is with the Ministry of Government and Consumer Services, so they're the ones who run procurement. They have already issued a primer that gives really good comprehensive information on what you can do under the public service guidelines. We're going to even take that to another step. We're going to find different ways to educate procurement officials, C-suites and hospital, long-term care associations, primary care networks, and even boards on the fact that you can do everything that we talk about as under the guidelines as written. We don't need legislative change. We don't need any of that. We're going to give them the clarity and the confidence you can do this stuff. Again, to try and help people get to where they want to go, which is to adopt and diffuse innovation in the system. I should say that we're also, I'm not going to get into detail our value-based innovation program, but I want you to know that, again, by the time your products get to market, we will have built a muscle within the broader system to actually look at a demand-driven procurement model where the system identifies the priorities, calls for industry solutions, matches them up, done in conjunction with the people who can actually help funds move across the patient journey. So when they leave the hospital, they go into community care or whatever it might be, and that gets tricky when you start looking at who's actually benefiting from the investment in innovation. And then also build the muscle so that people in the system who are going to take on this type of procurement effort will learn from the experiences of the people who have gone before them. It's no longer, a hero at Markham Stouffville or a hero in Waterloo, Wellington, Lynn, or whatever it might be. That person, he or she, will benefit from the experiences of the people who've done it before them. And so the system will build a muscle memory and become more fluent and better able, more agile to adopt and diffuse innovation like the kinds that you're bringing forward. Then the three areas that we've chosen to dig in, they're not going to surprise anyone, I don't think. Home and community care. The number one priority of the system is home and community care. Our Health Technologies Fund focused on that. You heard about one of the projects that I love the most, which is Markham Stouffville with Cloud DX. We're really, really optimistic about where that's going to go, and then our desire is to ensure that they get into the system. So it's more than just these 15 recipients in the first call don't just get, they're not just working with partners and money gets into the system and then there's a great pilot that hits all its milestones. It's not really a pilot, it's a value demonstration project, and then it dies on the vine. We want these things to get into the system. But the message from our Health Technology Fund that seems to have had the most impact is it's $5 million a year for 4 years. That's not that much money when you're talking about that $52 billion denominator. But we said that it was an opportunity to be the change that we want to see. So all these things I'm telling you about collaboration and partnerships, we're like, all right, we should put our money where our mouth is. So that slide shows who got the money. Health innovation teams. Actually, it wasn't individual companies. We said that health service providers had to identify a problem, pair up with a company with the solution, and an investigator or researcher, and then come forward as a team. So we forced all these conversations. There were 230 applications in round one after we called out the ones that were just fishing. Those were all conversations that were had as a result of this fund. We've heard from a number of people now that many of those would not have happened but for the fund. And in some of these cases, the companies are actually going to get contracts that they wouldn't have gotten before, simply because we drove the collaboration. We made it a prerequisite of the program, and we're really proud of that. The second priority, there's going to be lots more coming. You will be interested in the digital health strategy, which is going to be released imminently. Our priority isn't, we're not the ones delivering digital health, as it were. We're looking at how the tools and collaborations can come from Ontario-based companies and technologies and processes. That's our lens on it. I yearn for the day when there isn't a separate digital health column. I yearn for the day when there isn't a separate innovation office. As I said at the beginning, in 2017 and 18 and 19, generally in business, digital isn't a relevant adjective anymore. It's moot. Because to deliver a business successfully, to deliver those improved patient outcomes, if better value, it should just be part of how we do it. It shouldn't be a separate standalone. But in the meantime, digital health is very much a priority. And the third one, which is also a watch this space, is how do we enhance outcomes for Indigenous people in Ontario? If we went to a whiteboard and drew up a healthcare delivery system, it would look nothing like the one that's delivering woeful health outcomes to Indigenous people on the reserves. If we could apply the technologies, even just that we're aware of now, let alone what you're coming up with, that could fundamentally change outcomes for those people. And we're working on that priority as well. So here's where we're going. You've heard a number of these themes, so I just want to leave them with you. Demand-driven. You're coming up with awesome ideas. Here's how we make sure they work. Let's have the system identify priorities and then call for industry solutions to come forward. I don't mean overprescribe. There's that line that says if you ask for a pen, you'll get a pen. If you ask for a tool by which you memorialize your thoughts, we're getting pretty close, or that could take you in many, many different directions, right? So So it's not over-prescription, but it's also not a vacuum, so that we're just waiting for good ideas to come over the transom to the health system. There's too many of them. There are too many opportunities. So we need to find a place where the system is creating the demand. And you know who the demand drivers are? You are, as the citizens, as the patients. Don't be satisfied with healthcare that wouldn't match the community-centric expectations of going to a Starbucks or getting your hair cut or going to the bank. Demand more from the system. And when you do, that will also start to help the health service providers, the healthcare professionals who are in the same camp, create that pull for innovation into the system. Hopefully you've heard there's kind of 6 things that are going to govern our work going forward in addition to demand-driven. That call to action to tackle risk aversion. I kind of see that as our #1 goal. The notion of outcomes-based drivers, right? So the idea that instead of prescribing the pen or even a way to moralize thoughts, what if we just used outcomes-based identifiers? Reduce acute care visits by 20% by 2025. Reduce hospital falls by, reduce admission rates, whatever. And then let industry solutions come forward and pick the ones that work best for the system. Similarly, looking at the continuum of care rather than just individual silos. So it is every organization has silos. The health system certainly does. And as you know, again, the more that investment decision goes a row up or 2 rows up, the more likely it is that the person making the decision on whether or not to invest in innovation is actually the one reaping the benefits of it. Because otherwise, you might ask someone who's responsible for, nothing more than the emergency room budget to do analysis on things that potentially reduce infection rates, consumption of pharmaceuticals, readmission rates, all sorts of things. But that person, again, is not a bad person. They're just responding to what the incentives are around them. They might say, you know what, that's terrific, but that is not part of my budget. That's not part of what I'm getting remunerated on. It's not part of what my patients get judged on. So that investment decision, if it were up another level, for example, in that simple example, if that were made up a level, then the person investing in the innovation would also be the one benefiting from the lower admission rates, higher patient satisfaction, lower drug consumption, et cetera. Data and data analytics. Oh my goodness, we could go on about this, but it is so important, especially in Ontario, that we need to have data that's connected and we need to have analytical capability. And I'm just going to leave it there. You think of that value-based innovation program I talked about. One of the cornerstones of that is going to be we are open now to risk sharing or gain sharing agreements with companies. But that depends on establishing a cost baseline and then the savings line and capturing the delta. That means you need to have cost data, and then you need to have the analytical capability to figure it out, and that matters. And we don't have that in Ontario in the way that we're going to need to. So that's a really important topic. And lastly, I think openness will resonate with everyone. We just, increasingly throughout the system have to get more comfortable with the idea that we don't lock into a service provider or a technology provider that says for 10 years, we're going to give you all the answers to this situation. And we're going to give you all the innovation within the 4 squares of that contract. Instead, let's contract with people who are willing to be open, because that's where the best solutions will come from, right? I think, as you all know. So, finish with this. So I'm a pretty excited, optimistic guy, right? You imagine me at like the 3-month mark. And I went out for a drink with a friend of mine, and it was, I'm so excited about this job, like, it's such great people, and, we're making such a difference, and here's what I've learned. And she's like, so she's not a healthcare professional, but not a healthcare professional. And she goes, that's great, that's terrific, you love your job. So, in 2 years as a patient, what am I gonna see that's different? Perfect question. That is why we're doing what we do, what the front half of the room does what they do, and what all you folks in the back are doing what you're doing. It is for the patients. Again, it's also a great coincidence that those folks are going to be the innovation drivers. So I went back to the office and shared that little story about the drink with my friend and my slumped shoulders when she asked the question. That is an actual picture of the sign that's above our printer. So the team had this thing had the same effect on the team it did on me. They printed up the thing. That sits and reminds us every day of why we do this. And I hope it reminds you of why you're doing what you're doing. Have a great day. Do a great job. And I can't wait to see how it turns out. Thank you.